I'm Kirstie Haywood from Warwick University, England. In this presentation, we'll explore qualitative research for survivors and their partners, which describes the natural history of recovery and often unmet health and social care needs. First, we'll look at the recent American Heart Association Statement of Survival following sudden cardiac arrest and how historically we have sought to understand outcomes. We'll then explore recently published qualitative research, which helps to inform our understanding of the lived experience of survivors and what really matters. And finally, we'll consider the implications of this knowledge for outcome assessment and health and social care. Developments in resuscitation science have resulted in a growing number of cardiac arrest survivors. And for those who are discharged to home, a survival rate of 82.4% is estimated. And that's a growing number of survivors and their families who are living with the consequences of cardiac arrest survival. However, we know very little about the recovery process following this traumatic and unexpected event, or of the unmet needs of this growing and vulnerable group. In recognition of this, the AHA has recently published an evidence-based exploration of survivorship, described as the defining goal of critical care in the 21st century. A focus on survivorship considers an individual's health and well-being following treatment and until the end of their life. For example, how patients and their family networks are supported in their return home and, where possible, to their previous occupations and hobbies. So what do we know about survivorship following cardiac arrest? Well, we know that survivors represent a heterogeneous group, often with unique and complex needs. Long-term outcomes are far-reaching, impacting both survivors and their family networks across numerous cognitive, emotional, physical, spiritual, and social aspects of their lives. Historically, much of this evidence has been informed by more objective assessments of impact, which, although helpful, may not have the granularity to really capture what matters to survivors. That is, they lack this essential content validity. Moreover, we also know that, until relatively recently, clinician-based reporting has dominated in this area, with inevitable discrepancies between what outcomes that matter to clinicians and to patients. And as survival rates continue to increase, a survivor-focused assessment that takes into consideration their unmet needs and examines the quality of survivor over the longer term is required to inform the provision and prioritisation of tailored health and social care. So, how do we find out more about survival and determine that the outcomes we are assessing are sensible, relevant, and appropriate? Recent years have seen a growth in qualitative research which seeks to understand the lived experience of survivors. We are currently completing a meta-ethnography or a systematic review of published qualitative research to inform the development of the first survivor-reported outcome measure and have to date included 21 studies. This is an increase of 14 papers from an earlier review published just 3 years ago in 2017, which included papers up to 2015. This presentation will focus primarily on our own qualitative study published this year and conducted as part of the COSCA initiative, which sought to provide outcome reporting guidance for future cardiac arrest clinical trials, but we'll also make reference to the key papers included in our review. The key part of COSCA was ensuring that we understood the outcomes that mattered to a range of key stakeholders. So we interviewed adult survivors who were discharged to home, and they were interviewed between 3 and 12 months post-arrest. And where possible, separate interviews were also conducted with their intimate partners to explore their perspective of the survivors' experiences. At the time of the study, no database of UK survivors existed, and so recruitment utilised 2 existing UK registries, cardiac rehabilitation services, and screening for intensive care admissions at a local hospital. Following the methodological approach of interpretive phenomenological analysis, or IPA, semi-structured interviews supported a flexible conversation leading to an in-depth understanding of people's experiences at the time before, to the point of the arrest, and afterwards. And from a total of 21 survivors who were invited to participate, 8 agreed, which is an acceptable sample size for IPA. 5 of the survivors were male, with a mean age of almost 63 years and a mean time since hospital discharge of just over 6 months. We also interviewed 3 partners. The data analysis supported the development of an overarching superordinate theme of survivors being trapped in a disrupted normality. And this was underpinned by 5 subordinate themes listed here: existential impact, physical ramifications, the emotional consequences, limited participation in social activities, and altered family roles. Throughout the interview data, an overwhelming sense of being unable to move on in life was present, contributing to this theme of being trapped. This stemmed from uncertainty surrounding their cardiac arrest, its impact on family and social life, and its resulting physical ramifications and limitations. And when considered together, these aspects made it hard for survivors to contemplate a resetting of normality, which required them to accept that life could evolve even with the presence of illness. Our participants viewed their pre-arrest life as a gold standard against which they assessed their recovery. I guess what I've been trying to do is to get where I was before. One of the things they say to you is you feel like a new person, you'll be as good as you were, and actually you aren't, and you're not for a long time. And this is what, 8, 9 months now, and I'm probably 60% back, and I don't know how far that's going to go. The wide-ranging impact of the arrest influenced feelings of a liminal or ambiguous state, where survivors sensed being unable to return to life as they knew it, but uncertain about what their life ahead held. So let's now take a closer look at those underpinning themes. Survivors described being grateful for being alive. However, the experience changed their perception of life, providing an increased awareness of life's fragility. Moreover, the inevitability of death was heightened, and a subtle preoccupation with death appeared to interfere with an ability to move towards a form of resetting their normality. It's scary. I'm scared in case it happens again. I can't get to sleep because I'm thinking I'm not going to wake up. And a female partner suggested, I think it was quite frightening for quite a long time. The fact that he got no warning, how do you know it wouldn't happen again? And this existential vulnerability has been reported by others, with a fearfulness of the new reality being underpinned by an increased awareness of one's own mortality. Many have difficulty accepting how their body failed them, and a lack of trust appears to complicate their ability to move on. And this was associated with an increased dependency and vulnerability, which, if not addressed, it suggested may interfere with recovery and quality of life. Our participants described how new physical and cognitive symptoms limited what they could do in terms of mobility and interactions with others, and this in turn disrupted what they perceived to be their normal functioning. I just don't have the strength in my legs at the moment to even make it worthwhile to get on a bike at all. Someone will ask me the name of something and I can't figure what it is, and I'll remember it, but it'll be the wrong one, and I'll get it all twisted and it'll be something totally different. Symptoms reported in our study and by others include physical and cognitive fatigue, pain, often from ribs broken whilst being resuscitated, weight loss and reductions in muscle strength, and increased breathlessness. As exemplified by the above quote and widely reported by others, survivors and their partners commonly report changes in cognitive functioning. Poor memory, difficulties making decisions, and speech problems are often reported consequences. And this often became more apparent as survivors started trying to do more, re-engaging in activities with greater cognitive demand, and highlights the importance of reassessment of cognitive impairment following hospital discharge and into the first year post-arrest. Restrictions brought about by the physical limitations resulted in frustration. It does get frustrating when you think to yourself, I really haven't done enough work to feel this tired. And a common feature to our participants and reported by others was the fear and uncertainty about having another cardiac arrest. I have moments when I sit thinking, am I having pain in my chest? Is this because I've been exerting myself? Should I be thinking more carefully about what I should be doing, or does this happen to everybody? And I'm now a little paranoid about what happens. Moreover, mentioned frequently was a loss of confidence and subsequent low self-esteem. Dealing with these new emotional challenges made it very difficult to move towards a resetting of normality post-arrest. And other authors have also described a wider range of emotions experienced, including the fear and vulnerability, which often sits alongside the gratitude for being alive. And similarly, difficulties adapting to new challenges and an increased dependency on others was often underpinned by a fear of a recurrent arrest. Both physical and emotional changes affected survivors' pursuit of leisure activities as well as voluntary and paid roles. For example, survivors described how reduced physical strength and fatigue prevented them from taking part in previously enjoyed hobbies, with a resulting negative impact on their socialisation. For example, I did a lot of craft work, like these, and dolls' houses. I haven't got the same. I don't feel the same. I don't know why. It just disappeared. And a partner reported he could just not wait to get back to swimming again. He really couldn't wait, and he was very disappointed when the doctor told him he couldn't. Some reported adjusting their work arrangements as they found it difficult to complete the same tasks and hours as before. and these limitations contributed further to a disrupted normality which affected people's social identity. But in general, there is a limited understanding of the barriers to reintegration. Several authors have highlighted the importance of support and security to their recovery. Family and health professionals were key to this. However, hospital discharge was often associated with the loss of this professional support and security, resulting in feelings of increased vulnerability and isolation. Several authors have also reported similar fears and insecurity in survivors' partners and the need for professional support following hospital discharge. This failure of the healthcare system to provide adequate long-term support and security may contribute to fear avoidance behaviour, suggested by others to be an important barrier to successful reintegration. Life following a cardiac arrest is complex and challenging for survivors and families, and inevitably the event will shape future life and relationships. Our participants reported a disruption in their previous social identity, particularly within their own family networks, that was underpinned by a failure to undertake previous caring roles, for example, for their partners or grandchildren. And this disruption was also deeply felt by partners. I think it was more stressful for my partner than it was for me, in as much as when I was in hospital, I was being looked after and I couldn't be looked after better. But when I came home, the responsibility went straight back to her shoulders. We didn't get the same support, and I don't think from the community nursing that she deserved. Several authors have described role changes as a central feature of relationship concerns. For example, the diligent observation and monitoring by partners can create significant relationship strain, but this behaviour is often underpinned by significant increases in the spouse's anxiety and fear. Some participants mentioned strained relationships post-arrest due to a change in the survivor's personality or the burden of caring on the partner's own health. He's very impatient now. He gets more impatient with people, situations, definitely got a shorter fuse than he did have. And Brampton suggests that there's a new balance that is required, with many authors also suggesting that emotional support over both the short and longer term may be required for both partner and survivors. So in conclusion, the sudden and unanticipated nature of cardiac arrest appears to result in a disrupted normality that is challenging to overcome, leaving survivors and their partners uncertain how to manage. An awareness of this disruption and the many challenges encountered by survivors and their family networks is essential for all health professionals and may assist in determining where support should be prioritised. For example, where overriding anxieties about physical vulnerabilities is evidenced, psychological support for both survivor and their partner may be required before engaging in physical activity. Conversely, another person may need relationship counselling if a caregiver is being overly protective. The breadth and depth of impact highlights the importance of a multidisciplinary approach to long-term rehabilitation, providing the support and security that survivors and their families need to enable them to move forward to an acceptable new normality. Providing a tailored approach to rehabilitation requires robust and relevant assessment of survivors' unmet health and social care needs. However, historically, we've not been very good at doing this. Our growing appreciation of the significant and wide-ranging impact of survivor, both for survivors and their intimate partners and families, is contributing towards the development of a new survivor reported outcome measure or questionnaire, currently referred to as the Survivors Prom, which will, we hope, provide an accurate and relevant assessment of survivors' health and well-being with which to inform healthcare. To ensure that the survivor's voice remains strong, development is a collaborative affair. Whilst led by a team at Warwick Medical School, we are working together with survivors, their partners and health professionals, both in the UK and internationally, to ensure that it really does measure what matters. If you'd like to be involved as a prom buddy or to find out more, please don't contact myself or Charlie. Thank you very much.